Good morning, everyone. It's an absolute pleasure to be here. And the actual title of the talk is quite and it includes looking at epidemiology and various other things, I think is very ambitious. And to be able to do that and talk about some of the science that I've been undertaking over the last 7 years would be impossible. So I'm going to reserve the science till Wednesday, which is a plug for one of my talks on Wednesday, which is a bit shameful. But really, I think do I just click on this? Yeah. I think really the intention of the sort of course, the conference organisers was really for me to talk about the management of the critically ill child in Africa and what really are the pragmatics and pitfalls. So it's much more a sort of practical talk, reserving the science till Wednesday and just talking about some of the public health aspects of that. And the reason why I'm not going to talk about IMCI will become obvious in the next few slides. I think you always start with some number crunching, some of the epidemiology, and clearly, obviously, the child mortality is still raging. Over 10 million children are dying each year. 4 million of these are children in the first month of life. Nevertheless, of all the deaths, nearly 50% of these occur in Africa and 35% in Southeast Asia. Under 5 mortality, from what I'll call childhood mortality from now on, has been falling gradually from the 60s. There have been significant inroads into the mortality, and sort of globally it's been a gradual decline of about 3% per year. However, this is now arrested in many parts of the world, particularly in Africa, and I've stolen this slide from one of the people who've really brought this to this sort of world forum, that actually there is a silent emergency in child mortality, that actually this is arrested in the 90s, and certainly in some countries in Africa it's actually getting worse, and that's not just related to the epidemic of HIV. The Millennium Developmental Goals have trying to reduce childhood mortality by 2015, and on these current projections, they won't even be there until 2035. So, I've just touched on the Millennium Developmental Goals. While they're sort of a broad number of goals, the ones that relate to child mortality is goal number 4, to try and improve childhood survival and to reduce by 2/3 the 1990 figures by 2005. And really the focus of the programme has really been improved nutrition, access to safe water and sanitation, prevention through immunisation programmes, and also bed nets in malarious areas, and also early access to primary treatment that's effective through the IMCI programmes. However, what hasn't been articulated very well and really come into policy is actually what happens when children become complicated, when they need to get to hospital. In the final illness, between about 1/4 and 1/3 of children will access hospitals. This means that actually hospital-based management is very, very important and a highly cost-effective way of improving childhood mortality. But because the focus has been away from that towards community programmes, this area has been substantially neglected. So this is my one slide on IMCI, which is really a community-based programme trying to tackle the vast majority of childhood mortality, and it's been extremely successful and globally applied. The aim is to actually improve first-level care of all conditions and then identify and refer those who have priority signs to hospital. Why is this? As we've said before, that many of the deaths will occur in the community, and also many of the children who are referred, if they don't have some intervention before they go, will die before they even reach hospital. And obviously the concern, if one tries to focus on hospital management as a way to improve childhood survival, then this may actually deter from primary care. But as I say, the corollary is that when you actually get to hospital, when these children are referred, because so little attention has been sort of paid on sort of improving the quality of care there, then there is significant problems in relation to their management. And And so what we find is that most children will present to district hospitals, and whereas resources and funding has basically been largely focused around tertiary institutions and teaching hospitals, and therefore most of the critically ill children will be managed in conditions where resources are fairly inadequate, there's lack of central support for childhood programmes, little ongoing professional development, meaning that there's a few staff who have very poor morale, and all of these impact adversely on the quality of care in children. So really this takes me to actually the themes of my talk as by way of introduction of what am I going to cover as regards the sort of pragmatics and pitfalls for hospital management. I'm going to depress everybody by telling people about the reality of care for the average sick child in an African hospital. And then just run through one particular area that I've been interested in is fluid management, and we'll actually look at sort of some of the evidence base for that and some of the shortcomings by actually breaking up management into a syndromic approach where diarrheal disease, malnutrition, respiratory tract infection and sepsis are all managed by separate guidelines, and also many of the sort of misconceptions were probably applied to paediatrics maybe 20 or 30 years ago in many of these countries are still there in these guidelines. So here we go. This child's now, he's been identified through the IMCI programs in his peripheral clinic as having priority signs and has been referred to his local district hospital. He's a 15-month-old child who has a 2 to 3 day history of fever. He has some respiratory distress, and his mother said that when she brought him in, he'd had a brief convulsion, and now his conscious level is down. So he's going to be sent off to hospital. And what are the reality that actually affects the optimal care of this child? Well, many children will live in rural areas where access to towns are usually via a central road. There's many sort of blockages to actually getting them there. And I think really what I want to say is that many children will, as a result of this, present very late in their illness, where they've already begun to develop complications. Okay, sorry. When they actually arrive there, I mean, you could equate this to a situation of a refugee or an emergency program where you have hundreds of children in line ahead of you waiting for a single, do I have a pointer? A single doctor that's sitting on the other side of, in there. There's absolutely no triage that occurs, and basically one size fits all. And if you actually get through there, there's a sort of the sort of lines. Often children who were moderately sick have become critically ill before they're actually seen. Ideally, one would like an integrated team approach, reinforced by training, and obviously supported by good diagnostic facilities. But in many district hospitals, these are completely lacking. And actually, the reason why people don't really understand this is there's been very, very little actual critical review of this and very few reports in the literature about the actual quality and delivery of healthcare to children in your average African hospital. This is a work, it's absolutely superb work by one of my colleagues called Mike English. The only way that he could do this work was to actually work with the Ministry of Health, and so they would audit and evaluate what is the sort of delivery of healthcare at the hospital, at hospitals. And he just basically showed that there's a systematic absence of management protocols, and that the national ones were usually not followed. Failures to provide even basic standard of care. Because of the poor diagnostic facilities, most of the treatment decisions are based on bedside assessment alone, unsupported by diagnostic information. And even although there's a limited drug list, there was many problems with stockouts. So really that is the reality of what we're dealing with in most district hospitals. So that was the first theme. I think many of the solutions to that are economic, but I think that's probably just tries to set the scene. So when we actually move to the next, one of my next themes is actually looking at the evidence base for management. The WHO have been, if people have been reading The Lancet recently, have been criticised very heavily about its guidelines, saying that many of the guidelines actually haven't used systematic reviews and have not used experts who actually have to live with their recommendations. However, this is very different for inpatient management of paediatrics, there has been a group of researchers and clinical scientists who are involved with management, who towards the late 90s tried to influence the sort of and have direct input into the WHO guidelines through these series of publications. This is one of them that's a small pocket-sized book that can fit into the pocket of any doctors, and I suppose this is equivalent of IMCI for hospitals. I won't dwell on that, but I do think that there are still one or two shortcomings of this, and one is one I've mentioned before, that actually they've still maintained the structure of management around a syndromic approach. In other words, if you have respiratory signs, you will be channeled down a pneumonia route, given that even although a number of children who actually present with respiratory distress have acidosis and likely to have shock. So I think that there are some issues related to that. Sepsis or septic shock is not even mentioned in the guidelines. It's sort of it's embedded within the other syndromic approaches, and there still remains one or two physiological misconceptions, which I'm going to try and highlight through our child who's now arrived in hospital. So he's now arrived in hospital, and he's obviously in a lot worse state. The doctor that's seen him noted that he's now hypoxic and he's needing oxygen. He's got a rapid respiratory rate and increased work of breathing. He's very tachycardic and has a delayed capillary refill. And also the doctor notes, although he's not dehydrated, he certainly does have early signs of malnutrition. His weight for age Z score is less than -3. So this doctor wants to give some fluid, and if he actually goes and turns to the guidelines, he wants to know, well, who should be actually, is he eligible for giving fluids? He's got delayed capillary refill, and which solution should I give him and what rate? This child is being managed in an area that has malaria, and so he could have had one of any of these 4 conditions based on a bedside assessment and also clinical history, and each one of these has a separate management protocol. So when we're thinking about actually sort of what fluids should be given, I think one has to see this in relation to actually the world literature on fluid resuscitation. We've actually obviously been, which has been very much, as alluded to by Mark earlier on, that this has been very much driven through a consensus approach. But if you actually try and look at sort of volume expansion and resuscitation trials, although we've tried to sort of extensively look at this in a number of conditions, unless there's quite a lot of unpublished data, for as far as randomised controlled trials, we were only able to find 8, 3 of which have been, or 6 of which have been done at 2 separate centres, one at our own in Malaria and another one at Vietnam that was mentioned earlier, at a Vietnamese unit in dengue shock. There's only one that's been done in acute diarrheal disease with a fairly small number of children, and one in septic shock in India. So actually the world evidence base for the sort of which fluids to give and how much and what rate, as far as being defined through randomised trials, is not great. But if we go back to the decisions that this doctor's going to have to make, now this slide's a bit of a mess, but it shows you what a complete and utter mess it is to actually make a decision about how this child's going to be managed. So this is the 2006 guidelines. Remember, in Khalifi we've been doing a programme looking at fluid resuscitation for 10 years now. And the 2006 guidelines suggest that with severe malaria, if you want to give fluids, you should only give fluid if a child is dehydrated. They suggest if you think that the child's got shock, they're not convinced by the world literature, and that you should only give fluid to ensure a CVP is raised to is levelled between 0 and 5, which shows how the lack of sort of physiological understanding of the people who've written the guidelines. No fluid is specified, but it obviously suggests that it should be tied into infusions of quinine, which are usually run over 4 hours. So that's severe malaria. With shock, or any child that comes in under the sort of emergency triage, they suggest that the only children who should receive fluid have got to have all three of the following, which is cold hands and feet, which equates to a temperature gradient, a capillary refill of greater than 3 seconds, and a weak fast pulse. They suggest to give 20 mils per kilo of Ringer's lactate, but also spend significant passages cautioning about fluid overload in these children. So even if you were going to consider giving fluid, you would still be quite frightened by that guideline. The one that really gets my goat is the one with severe malnutrition, that actually most children are suggested that you shouldn't give them fluid resuscitation because they're concerned that you put them in cardiac failure. You've got to have all of these signs plus impaired consciousness before you're given fluids, and the fluids that they're given are half-strength fluids, 15 mils per kilo, and if you don't get any better, then you get a blood transfusion. And for those people who work in the tropics, access to emergency transfusion is terrible. It usually takes at least 3 to 4 hours to organise that. In effect, it's a very poor guideline. And I think the only guideline that's actually any use in terms of giving large volumes of fluid is children who have severe dehydration. I'm sorry I've laboured the point, but it just shows that actually if you're trying to make clinical decisions at the bedside at the moment using the WHO guidelines, they're very confused. So what really happens in reality? In most malaria settings, because sepsis has not been raised to prominence, most people don't do bacterial cultures. Malaria is often overdiagnosed, and therefore that means that sepsis and other conditions are underdiagnosed and undertreated. I will show in the next couple of slides, there is significant overlap in clinical presentation, and even they actually sometimes coexist in the same child. And given the fact that looking for supportive laboratory confirmation usually takes hours, that means that they'd be far too late to help manage these children because early mortality is substantial. I just flagged this up to show you that if you actually just we have a definition of severe malaria which is impaired consciousness and/or deep breathing. And this is a randomised trial that we're doing comparing quinine and artesunate. We see that 200 of children have been entered into the trial, but at least another 200 children would have been thought to have been eligible. And in a hospital that has limited diagnostic facilities, or that they're not confident with their malaria diagnosis, that means that another 200 children that probably had bacterial sepsis would have been treated for severe malaria. And the reason for this is the fact that it's almost impossible at the bedside to differentiate the pathologies. This is data from Khalifi over the last 3 years, showing that actually the range of complications and presentations is almost identical, the priority signs. The only feature that really discriminates between the two is the obviously the kids who have signs of pneumonia, which really distinguishes bacterial sepsis. And this is culture-proven bacterial sepsis. And the other thing that distinguishes is the very, very high mortality. Waiting for confirmatory data is probably not rational either. We see that this is data from the same two data sets showing you the very, very high mortality on the first day. Over 50% of the deaths will have occurred by 24 hours, and most, because you see the very steep kick-off, most will have occurred within hours of admission. So if we go back to this recommendation of who should receive fluid, according to the WHO, remember that you need... This comes directly from their guidelines, that you need all 3 of these signs before you should give fluid. Well, we've looked at this, and this is our children with bacterial sepsis, which we showed before, which we would have believed that actually probably had shock, that only 7% of those children using the WHO guidelines were identified as shocked. And if you see the actual mortality, it's a syndrome of just too few and too late, really, that they're just identifying children that are about to die effectively to give them fluid resuscitation. And in fact, meaning that most children don't receive volume expansion. And I mean, we work at a hospital where we've had a culture of giving fluids and also training our personnel to actually assess signs of shock. And many people might be sceptical about, well, I don't think that these are very valuable. We also have access to large amounts of data where we can actually look at this, and this really shows how you can, on simple bedside assessments, make a decision about whether you can give fluid resuscitation on a more practical approach. We can distinguish children who have signs of severity, and we find that at least 50% of those will have one sign of shock, which is either a weak pulse, a delayed capillary refill of 2 or more, or a temperature gradient. And we find that discriminates a group of children who actually have a high mortality. So what I'm trying to show in this slide is that actually decisions on fluid management can be made on bedside features alone and on a fairly rapid assessment. My other theme was that actually that the guidelines are peppered with many of misconceptions, which again inhibits people from giving fluid resuscitation because they're concerned that it may may do harm to the children. And I this is directly out of the guidelines, suggesting that the commonest sign of fluid overload in children is an enlarged liver. Now, these are, again, the same data set that I've shown you before, and this is admission signs of when children come in. And you see that nearly a third of children will have a sign of enlarged liver. This is usually due to a displacement of the or apparent hepatomegaly, because the children have increased work of breathing. So actually, you'd say that at a third of children you would withhold fluid from, and who are shocked just on the sign of an enlarged liver. Although they suggest that gallop rhythm is also a very good sign, we find that is the vast majority of our children who come in with shock have some degree of anemia and do have a gallop rhythm. And also looking for fullness of the neck veins, which I think has been abandoned years ago in paediatrics. But I challenge any person to actually get that child to sit upright so you can see whether his veins are full in his neck. The other major misconception is the fact that they don't really adequately distinguish between hypervolemia and dehydration. And I'm trying to illustrate the difference between these two. The child on the right-hand side is a child who has severe dehydration. He's come in, he's about 10% dehydrated. But as you see, he's actually still looks very bright. And with fluid resuscitation, his prognosis is very, very good. Whereas the child on the left-hand side has hypervolemic shock. He has decompensated shock, where he needs large volumes of fluid shortly after admission. And on the current definitions, he probably wouldn't receive these. His weight has not changed from the pre-morbid conditions, and the fact that people are trying to look for those to actually give fluid resuscitation means that many children don't receive fluids. So that's all terribly depressing, but the practicalities of what we're having to deal with in the sort of research settings that we're doing with. So I'm going to try and move forward with a sort of finish on a note that's a bit more positive. This is a slide that's already been shown, and has shown that actually you don't need specialists to improve outcome in paediatric sepsis. You don't need paediatric intensive care units. That actually most of the gains in survival come through non-specialist management, through community physicians, through first-line staff. And we're hoping to actually try and move that concept into the management of children presenting in the tropics. We're about to undertake a large phase 3 trial that recognise all of the sort of practicalities of managing these children, using non-specialists and nurses to make decisions about fluid management. As a result, because you can't differentiate effectively sepsis and malaria, we will do a malaria and sepsis trial in parallel. We will use bedside criteria to enrol children, which means that actually the results of the trial will be relevant to the clinical practice, rather than a trial that's based on entry criteria that require point-of-care analyses that are just clearly not available. We will do a 3-arm trial which involves a control arm, which would seem a complete anathema, but given the fact that most children don't receive fluid resuscitation, we feel that this is a fair assessment of the current features. In the control arm, we will have provision for rescue therapy. And we hope that if we show that the benefits of volume expansion in these two groups are confirmed, that we can actually start to now flag up that actually taking a paediatric critical care or an emergency care approach to management may improve outcome. That actually that protocols can be implemented through this bedside assessment, and hopefully this will be a rationale for change, a change in the sort of culture of early management for children. We hope will dispel all of these misconceptions about fluid resuscitation and lead to major changes in policy and hopefully optimise child survival. And although I'm not going to make any recommendations for the actual scope of the global sepsis programme, I think one should be of advocacy and to really sort of try and highlight the fact that the actual revolution that's resulted in a massive decrease in mortality of sick children in the sort of rich West countries has just barely affected sick children presenting to hospital in developing countries. that if we can prove through a sort of protocols and trials that show that effective delivery of care through and through simple simple targets can result in an improved outcome. But I think that any programme that tries to aim to do this obviously has to recognise that you have to have a functioning hospital sector to be able to do this. And I think that's my last slide. Thank you.